Yeah, so this is the life of an interventional radiologist. You get early to the hospital to see your patients that are already here and then get ready for all the procedures today. Sunny day in California, that makes it easier to do that, right? Hey. So this is a patient, she's 92, and she has severe back pain for the past couple of weeks. And you can see she has chronic back pain because she has a severe scoliosis. But what happened to her is, unfortunately, she developed a new fracture of the L3 vertebra. And this is a very difficult case because of her spine is so crooked. But what we do to treat this is we are able nowadays to go under, guided by x-rays, and we can actually be very precise. So in this case, this is the vertebra that is broken. The other ones had fractures before, but they are already healed. This is the one that is causing her pain, and you can kind of faintly see the fracture line here. And what we can do is, guided by x-rays, we can insert a needle into this vertebra, and through this needle we can actually inject an epoxy-like material inside the vertebra to kind of stabilize this fracture and improve her pain. This will tremendously improve her recovery. And when you're 92 years old and you have a fracture and you're not walking or doing the things that you normally do for a few weeks, you get so debilitated that may take months for you to get back to your normal self, or you may never be able to get back. It's really a problem when you get older. So we're gonna go check in with the team to see what else we need to do today, and we're gonna start seeing the patients. How busy are you guys this morning?
Doctor, we're all booked up.
Oh, yeah.
Put the patient next to that one more time, or you already had MRI order?
I put the order, yeah. Normally a full MRI of the back takes about 30 minutes or so. It's very difficult for the patients because they have to go in a very enclosed area, right? So patients are claustrophobic, they may have problems with that. But the MRI of the back per se doesn't take that long. But in this case, because all we want to know is which of the fractures are actually acute, and I want to make sure she doesn't have any other problems, we can make an abbreviated MRI that will only take 10-15 minutes. So. Hello.
Hi.
Hey, Dr. Komlos here. How are you? Okay. Hey, how are you? Which ones?
There's a couple biopsies. I think there's, mostly I saw biopsies.
Okay. Yeah, that's fine. What's going on?
Fabio, how are you?
Good. Yeah, so without any treatment, these fractures can heal, but the patients can take months to be able to recover. Usually, after undergoing this treatment, in a few weeks, they start going back to their normal life. Of course, the procedure is so minimally invasive that there's not really a recovery time from the procedure itself. It's more recovering from the fracture that you already have. It's not like open surgery where you have to heal from a big incision in your back and your tissues have to heal. This is all done through a simple needle stick. So the procedure per se does not have any recovery. The success rate will depend on how long this process has been going on, and also will depend on us making the correct diagnosis that the pain is related to this fracture. If the pain is related to this fracture, the success rate is pretty high, like in the 90% range. 90% of the patients will get better after this procedure. Right here is where the bleeding is. And it's coming down, so we'll have to navigate all the way here pull up here, go into this small vessel, and then we inject some glue in there to kind of stop. Okay. Can you open the glue? Okay.
Open your true fill.
So this is the type of catheter that we use.
Expiration date is
It's a very thin catheter. It's less than a millimeter. And it's very flexible. Can you push it up?
How do you decide when to use glue versus coils?
I think glue usually works better because the coil, if you have a collateral, the coil will block that vessel but won't block the collateral. The glue will block the whole thing, right? Here's the glue. We'll mix the glue, which is, it comes inside a vial. And we connect to this, and we'll take the glue. And we only need a little bit, so this is 0.7. And we mix the glue with a solution called thiodol. Mix that all together. All right, I think that's it. Well, we're doing the drain today, right? Like,
Yeah.
I think they can load right after this. This is going to be a cute cool.
It is.
Thank you. Sedation only.
So this is a patient that we placed a dialysis access in the arm, but the access is working well, but they're having difficulty accessing because it's too deep. So we're gonna do some sort of liposuction over the access so we can make it easier to be used. And we're gonna need the ultrasound, so can I have the light? No, take the microcatheters needle. So this is the celiac trunk. Oops. So this is the endograft, right? And you can kind of see the contour of the aneurysm, which is right here, right? Yeah, so this patient had a AAA repair in the past, and his sac continued to grow because something called an endo leak. And we were able to find the blood vessel that was feeding the sac and making it bigger. And we injected a glue material called onyx in there and also blocked that blood vessel. So that should help for the sacs to stop growing and even get smaller.